Ray is the chair of radiology at the United Medical Center here in Washington, D.C., and Ray's has taken on this task with great enthusiasm. It's a fairly Sisyphean task, and for many of us, I think Medicaid is not something we necessarily spend a lot of time thinking about, but when you've heard Ray's talk, I think you're going to understand it's going to be a much bigger part of what we think about every day. So thank you, Ray.
Thank you very much. I'm Raymond, too. I have no disclosures. I thought the format of my Medicaid update would basically give a small vignette on the background of Medicaid, and then to talk about some of the implications of the Affordable Care Act, and then look at some regional vignettes. We have been very active in obtaining conference calls, meetings with states' medical directors in targeted areas, specifically in the Pacific Northwest and the upper Northeast areas, and I'll share some of those reports with you in my report. So the targeted areas which I specifically looked at was Seattle, Washington, and Bethlehem, Pennsylvania, and I spoke with some key people in those areas. One of the things that I quickly learned is that there is variability in the steerage of Medicaid patients across state borders, largely due to expertise of care available in the native areas, and also maybe partially due to reimbursement. So this was a very interesting phenomenon. The other thing I also quickly learned is that there is a lot of information on Medicaid data out there already. And I know that if any of you are interested in health policy and you sign up for all of these health policy summaries, you will quickly get bombarded with information. But what I also learned is that there was very little radiology-specific actionable information. So the story of what I'm speaking about really started 50 years ago, but really what we're looking at is what happened just a few years ago with the Affordable Care Act. And basically what the Affordable Care Act is going to do is expand health care coverage. If you read this little vignette that says 18 million Americans over age 65, low incomes, they need health care, home health visits, you would say this sounds like just like what's going on now, but this is exactly what happened when this was signed back in 1965, almost 50 years ago. Here, just down the street, this was signed. Again, reference to Franklin Roosevelt, Teddy Roosevelt, getting you really excited. It says, everybody should have some basic security when it comes to their health care, applause. It sounds like the story 50 years ago, but this is the story that just happened back in March 2010. Just like what Bob said, if you look at Medicare, Medicare is conveniently broken up into regions, and we have various jurisdictions. So there are care advisory committee members where people in different regions can get together, look at the LCD proposals, make their calls, and really have a voice into what the policies are. But that's not necessarily true with Medicaid. And the reason why the Affordable Care Act is very important is the implication of this onslaught of people with a card saying, I'm here for my care, now I can have it. And you can look at this report from Regents, another one of those many health data reporting things. We're going to have an increase of 9 million additional exams in California. I mean, that's a lot of exams, and the reimbursement rate is going to be quite low. The implication for consolidated impact is 13.6 increase in existing volume, or 61 million additional procedures nationally. So what does this mean? Well, it means that we're all going to be very busy. Again, Kaiser Family Foundation, if you just search it, Kaiser Family, they have some incredible tools. It's almost like booking your airline reservation. You just click on a state. There are a lot of drop-down menus, pie charts. You can look up your states, different products. But again, all of these very beautiful and fancy search tools are not imaging specific. Again, Kaiser Health News, they're really terrific. I get a blast in the morning, I get a blast in the afternoon. My email queue is just packed with this stuff. It just drives, and on the bottom it says, want to look younger, help has arrived. I mean, all of this gets kind of mashed in my spam box, yet it's really important stuff. And I'm going to talk about a little bit about the granularity of Medicaid and why it's so important. And the reason is that Medicaid is just a small component of this with respect to state coverage. There are people who don't qualify for Medicaid or Medicare, and locally that's called Alliance. So there are patients who don't fall into any of these categories, and yet they have some type of safety net coverage through a program called Alliance. So again, there are 47 states that manage Medicaid, and the reason why is because this is a way to barter down costs, to control markets. And if you look at managed Medicaid, or just Medicaid in general that's managed, it has really increased in number. So what does this mean for locally for all of us? Well, it means that you could fill this room with managed Medicaid contractors, which means how do you negotiate these contracts, and how can the college manage all of this variation? So you can look at the states, and there are a huge number of managed Medicaid contracts. So if you're a radiology group thinking that politics are really local, really Medicaid is local, and this is an example of one of our contracts here, chartered, and you have to go through all this little fine print, and I made it very fuzzy so that you really can't see the details. But, kind of buried in there is that you see their Alliance program is the insured program of last resort. So again, you have to make sure that if you have a patient who, quote, doesn't have insurance because they may not have brought their card or whatever, that they do or do not have insurance, or they're part of the Alliance program. This is a local vignette, but still, it's very, very confusing. And imagine if everyone in this room had a similar contract, you can imagine that if you had a question, that the college would be quickly overwhelmed with how to address these concerns. So you can spend a lot of time looking at fee schedules and, figuring out who's going to get it, at what rate, and are you going to outcompete your neighbor down the street or whatever. But this is an example of what happened here in DC on Chartered, which is that nice contract I showed you. Chartered started in the 1990s. It was acquired in the 2000s by someone locally here named Jeff Thompson. Then in 2012, Chartered went under DC receivership because auditors found some financial irregularities, because you have to have a certain amount of funds in the account. And then in February, this past DC Superior Court approved a plan to sell Chartered for a mere $5 million. So here are some clips from our local story, which each of you will have the same local story. Here's an example of a AmeriHealth Mercy family of companies who did assume control of Chartered, and there's $5 million of assets to pay for $45 million of leftover claims. Now, this is Washington, D.C. So you get a little pop-up email that says, welcome aboard. Good news for you and your community. D.C. AmeriHealth is in your community now to take care of your D.C. managed Medicaid patients. But then you get a mysterious fax the next day. It says provider claims are being suspended. And yet you have patients in the pipeline getting their imaging studies, getting their MRIs, getting their PET scans. What do you do? Well, imagine if this is multiplied by nearly 400 times. That is the granularity in which the college will have to address Medicaid. So what is the ACR Medicaid network? Well, is it just a data suppository of data? Well, it has to be radiology-centric, because there are a lot of other data repositories out there, like Kaiser. It has to be searchable. So let's say that if, like Utah, has a question about x-rays of the toe, and is it going to be bundled with MRI of the knee or something like that? Well, you have to search this data, and there's so much data out there. The college is looking at methods and search engines to sort of search these data, these bits of data which already exist. It has to be actionable. We're going to have 61 million additional procedures. Well, what does this mean? What type of procedures? Where are these procedures occurring? Well, these are the things that the college is looking at and really realizing what needs to occur. We were thinking about maybe having various radiology groups submit their contracts, saying that we will, keep this totally in confidence, non-disclosure, to look at how our various Medicaid contractors, nearly 400 of them, are varying their contracts in order to provide the least amount of reimbursement. Some ideas. The college is really interested in high-level analytics, and this is an example of using Medicare-Medicaid ratios to try to figure out the story of some variability throughout the United States, because it's very complex, it's very granular, it's very local. Again, this is Bob's, the various jurisdictions of Medicare, but if you just look at the managed care organizations, well, look at California, that's jurisdiction 1, but there are 56 products. Look at Texas, there are 50 products. Look at us, there are 95 products. I mean, if you look at J12, there are other 95 products. So this becomes very, very complex. So data mining will be very, very important. That will be radiology-centric. So I would say that the ACR Medicaid network mission statement, again, is to monitor Medicaid policy and funding, but also I think we have to make sure that we look at impact, actionable impact information, looking at imaging delivery. And please, if there's anything locally that you want to share with us in the Economics Committee, in the Medicaid network, please let us know, email us, and we'll be sure to include you in our listserv. Again, as I mentioned, I had pooled various states' medical directors of Medicare and boards of medicine. I looked at targeted areas, and again, I think the overall reaction is that we don't know. Thank you very much.